next up is our next speaker, and I'm exceptionally delighted to be introducing her as well. Dr. Stimming, who Dr. Anderson referred to, is also at UT Health. I just want to say, I'm going to read her list of accomplishments, mainly because she deserves it and more, but also I want our community to know what exceptional people we have working on our behalf. It gives me so much inspiration to know that these power hitters and all-stars are working on behalf of our community. So bear with me as I introduce not only a professional colleague, but a good friend who joined our Huntington's community many years ago. And I have to tell you, this amazing program that you're hearing about from UT Health, Dr. Stimming built that. I remember I met her before anything was ever established. So kudos to you, my friend. I'm going to launch in. Dr. Stimming, she's a professor in the Department of Neurology at the University of Texas Health Science Center at Houston McGovern Medical School and a fellow of the American Academy of Neurology. She is passionate about treating the underserved, and as a result, she served as the chief of neurology at Lyndon Baines Johnson Hospital for 7 years. She is the founder and director of the HD Clinic at UT Health McGovern Medical School, the only Huntington's Disease Society of America Center of Excellence in Texas, and one of 4 level 1 COEs in the nation, which now includes partnering sites outside of Houston, because she built that, right? She serves as the neurology clerkship director. The important point about this is she's training the next generation, because she's training them in Huntington's disease. Amazing. She's received the Dean's Excellence in Teaching Award every year since 2009. She has received the DuPont Master Clinical Teaching Award, and she is a member of the Academy of Master Educators and a McGovern Society leader. She continuously strives to enrich the educational experience of the students, residents, and fellows. She is the chair of the American Academy of Neurology Consortium of Neurology Clerkship Directors. She has been named a super doctor by Texas Monthly and a top doctor by Houstonia magazine for the past several years. She received her medical degree from the Chicago Medical School in 2003 and completed her postgraduate training, including a neurology residency and movement disorder fellowship at the University of Texas Health Science Center at Houston, where she became an assistant professor of neurology in 2007 and promoted to full professor this year. Congratulations. Dr. Stimming is actively engaged with the Parkinson's and Huntington's disease communities. She is the chair of the Medical Advisory Board for the Houston Area Parkinson's Society and a member of the local HDSA affiliate, and frequently volunteers for both nonprofit organizations. She continuously served as the president for the Texas Neurologic Society, the largest state neurological society in the country. She is currently the vice president of the Houston Neurological Society and chair of the Education Committee for the Texas Neurological Society. Dr. Stimming is the PI of multiple HD clinical trials and collaborates closely with basic scientists at UT Health McGovern Medical School to enhance and optimize treatment for individuals living with Huntington's disease. Dr. Stimming, thank you for joining us this morning.
Oh my goodness, that was just such a lovely introduction, Terry. Thank you. And you are such a hero and a legend in the land of HD. And I'm so honored to receive that introduction from you. And yes, remember meeting you long ago and learning from you. So thank you. Okay, so I'm going to share my screen here and we'll go ahead and get started. Okay. So let me put it in present. Okay, so hopefully everyone can see my screen and hear me, and we'll go ahead and get started. Thank you to Dr. Anderson for a lovely presentation. That was just fantastic. Thank you for the overview of the cognitive symptoms of HD. So I'm going to talk to you this morning about the motor symptoms of HD, since I'm a movement disorder specialist, and address the motor symptoms of HD. I have one video, and I'm so grateful to our patients for providing informed consent to allow us to educate our students and our patients about HD and what HD means for our patients and families. So we have many slides to get through, and I'll try not to rush too fast, but I want to briefly give everyone an overview of Huntington's disease, and I'm fairly confident that most folks watching could do that for me. But just to orient us, we'll talk briefly about the motor symptoms, an overview of motor symptoms, and then we'll go into a little bit more detail about what those motor symptoms mean for us. And then we'll talk about treatment options briefly as well. Everyone is familiar with this, I'm sure. What is HD? It's an inherited neurologic disease, and it's generally characterized, as you all know, as a symptom triad. And the triad includes motor symptoms, psychiatric symptoms, and cognitive symptoms. And so we'll talk today about the motor symptoms. I want to point out a couple of, I think, really important points here. So we know that most individuals become symptomatic in their 30s or 40s, but some individuals become symptomatic much younger, and some individuals become symptomatic later in life. At the end of the day, it's important that everyone knows that everyone is on their own course. We know that HD is an inherited disease, so most of our patients have seen their parent or grandparent or sibling live with HD, but everyone is on their own course and manifests symptoms in their own way. And so I think that's an important reminder to all of us. It's also important that we are well aware of the fact that there are, in fact, effective symptomatic treatments available, pharmacologic and non-pharmacologic, but there are always things that we can do to try and help our patients in improving their quality of life. So what are the motor symptoms? Excuse me, what are the motor symptoms? So this is just an overview, and we'll go through these in greater detail. But chorea is probably the most common motor symptom in adult onset Huntington's disease, but we know that chorea is not the only motor symptom. So our patients also can experience an impairment in their voluntary movements, and then some other hyperkinetic movements that I'll define in just a moment. So let's start with chorea. What is chorea? Chorea is defined as a random movement. It's an involuntary movement that's non-rhythmic, and it may appear as a movement that kind of flows from one body part to the other. It's derived from the Greek word to dance. Often you may see an individual with chorea and it may almost appear as if they're dancing. We know that over 90% of adults with HD will have chorea at some point in their journey with HD. And we generally think of chorea as a core feature of HD. Interestingly, like most hyperkinetic movements, we know that chorea can increase with stress or anxiety, even with depression. So that's important when thinking about addressing chorea. It helps if we're in a calm, predictable environment, which it feels like our world has been far from that, as the sky has been falling for quite some time now. But if and when we have an opportunity to calm down and de-stress and maybe think about deep breathing and meditative techniques, those can be very helpful in at least transiently decreasing chorea. I want to mention here anosognosia. That is, it's a big word, but essentially means lack of awareness or lack of insight. And this is not terribly uncommon in individuals with HD. And I think it's important for our care partners to be aware of this, especially in relation to chorea. An individual that is experiencing chorea may not actually be aware of the chorea or the severity of the chorea. And so we really need to get input from our patient's family and friends to determine what the chorea, how the chorea is impacting their day-to-day quality of life. Also, importantly, chorea can and should be treated if needed. So how does chorea impact our patients? What we've defined chorea, we know it's an involuntary movement, but what does that really mean from day to day? When I ask my patients and their families, they may say, you know what, it's actually embarrassing. I'm at work or I'm visiting with friends and family, and I notice maybe that I'm moving a little bit more than everyone else, and I find that to be embarrassing. Sometimes that doesn't occur because, as I mentioned, sometimes individuals don't recognize that they have chorea, but if they do recognize the chorea, it can be embarrassing. It can make it very difficult to use a smartphone or a computer because of the involuntary movements and incoordination that can occur as a part of HD. It can make it difficult for our patients to perform simple tasks that maybe aren't so much as too much fun and maybe aren't so enjoyable. That loading the dishwasher can be very difficult, as you can imagine. If you have involuntary movements and you're trying to coordinate placing a dish in the dishwasher, that can be challenging, and we can have broken dishes. They can make it difficult for our patients to maybe apply makeup. I've had individuals tell me it's really tough for me to apply, say, mascara because of the involuntary movements. So those are some examples of how chorea can negatively impact day-to-day activities. We can also hear from our patients that they have slurred speech. They have some difficulty with articulation of their words or dysarthria. Our patients can describe difficulty swallowing, maybe report coughing or choking after eating or drinking. Unfortunately, we know that our patients can have a tough time keeping up their weight. And if you can, only imagine if someone is moving continuously, they are burning more calories than an individual that doesn't have chorea. And so chorea can lead to weight loss. Unfortunately, chorea can lead to frequent falls. And so that can be very problematic for our patients, and thinking about wanting to keep them safe and avoid injuries. So other ways that chorea can impact our patients, and I've mentioned indirectly a few of these, but we know that our patients will report that they're dropping items frequently, or knocking items over. If they're trying to eat or drink, they might find that they're knocking over their water glass, or having a tough time coordinating getting the food onto the fork or the spoon and effectively getting that food to their mouth. Our patients can have recurrent falls or near falls. They can stumble because of the chorea. And our patients will often report, or their care partners will report, that they're having more difficulty with gait and balance, which, as we know, can lead to, as I mentioned, falls and potential injuries, which we certainly want to try to avoid. So how do we evaluate chorea in the clinic? How do I evaluate my patients as a movement disorder neurologist? What tools do we use to assess the severity of the chorea? Most often in our clinic, we use something called the UHDRS, or the Unified Huntington's Disease Rating Scale. And this is a validated scale that measures several clinical features of HD. So I focus on the motor section of the UHDRS, but there's a cognitive section, a behavioral section, and then an independence section of the UHDRS. And this was a scale that was developed by the Huntington Study Group and published in 1996, so many years ago now. And it can be very helpful both for clinical and research purposes in really objectively measuring the severity of the symptoms, both the motor and the non-motor symptoms of Huntington's disease. So this is just an example of the chorea, the way in which we measure chorea within the motor subscale of the UHDRS. So we essentially measure chorea in different body parts, and we measure the severity of the chorea. So the higher the number, the more severe the chorea. We measure the chorea in the face, in the frontalis region, and upper face. We measure the chorea in the bucco-orolingual region and the lower face. We measure the chorea in the trunk, the neck and the trunk. And then we measure the chorea, the severity of the chorea in each limb independently. And we sum the score, and this can help us when we're maybe using a medication or an intervention to treat chorea and determining whether or not we're making progress in effectively decreasing the chorea. So here's an example of me asking my patient to perform some tasks that are part of the UHDRS motor section. So finger tapping, pronation, supination. So you see, we're asking the patient to perform some different tasks. And the entire time we're visiting with our patients, besides having the luxury of catching up on important pieces of their lives and hearing about their family and friends, we're able to observe their movements and whether or not, in fact, our patients are struggling with chorea or in coordination. We can evaluate their gait and how they're ambulating and whether or not we need to intervene with medication or other non-pharmacologic strategies. So we've talked a good bit about chorea, and we've defined chorea. How does chorea differ from other hyperkinetic movements? So we know that our patients can experience dystonia. What is dystonia? Dystonia is sustained contraction of agonist and antagonist muscles. So it's often described as twisting or turning movements. And our patients can have chorea and dystonia. Our patients may have tilting of their trunk, or they may have elevation of their upper extremity or their arm while walking. Dystonia can be painful. Luckily, it's not usually painful, but especially if our patients have dystonia in their neck, they can experience some discomfort. And so we want to make sure that we address that dystonia, especially if it's painful for our patients. Myoclonus is another movement that's not quite as common in individuals with HD, but it can occur. Myoclonus is a really fast movement. We have all experienced myoclonus. If you've ever been maybe falling asleep, dozing off, starting to take a nap or go to sleep, and all of a sudden you awake, that's actually because maybe you are dreaming that you're, say, falling off a building or falling, and you quickly awaken. That's a form of myoclonus. It's a very fast movement. Actually, hiccups. We've all experienced hiccups at one time or another, and that's another form, a physiologic form of myoclonus. But there are pathologic forms of myoclonus, and they may occur in HD. A tremor is another movement that's not quite as common as maybe dystonia or myoclonus, certainly not as common as chorea. Tremor is uncommon in individuals with HD, but it can occur, and a tremor may even occur as a side effect of a medication. But a tremor is rhythmic. Unlike chorea, that's arrhythmic, a tremor is generally rhythmic, and it's a rhythmic oscillation around a joint. A tremor may occur when the limb is at rest, or it may occur when you are actually using your limb. And so tremors can be problematic, and if needed, we may treat them with medications or a modification of the medication regimen. So a few other definitions here, tics. So tics can actually occur in HD. A lot of folks think of tics and only occurring in Tourette syndrome, but tics can actually occur in HD, infrequently, but they can occur. So tics are stereotyped movements. And generally, tics are preceded by an urge to perform the movement. And our patients will tell us that they have the ability to suppress the movements. Rigidity is not something that our patients will necessarily describe, although their care partners might say, I noticed that my loved one is a little bit stiffer. They're having experiencing an increase in their tone. So rigidity is assessed when we're visiting with our patients. We assess their range of motion. We extend maybe their upper extremity, and we'll feel a resistance to that range of motion. And so that's rigidity. There are different types of increase in tone, but if we need to, we can treat or try to decrease the rigidity with medications and practicing range of movement exercises. Bradykinesia is a description of slow or small movements. So a slowness of movements. And then ataxia is just incoordination, an incoordination of movements. So how do the motor symptoms evolve in HD? And don't worry, I won't quiz you after we're done. I know there have been lots of definitions, but I suspect that at some time throughout your journey of HD, you'll hear those terms or read about those terms. And so I just want you to be familiar with those terms. So we know that in early HD, our patients may have some changes in their coordination. They may describe a little bit of trouble with handwriting. They may have some difficulty with fine motor movements. We've talked about some of those already. Interestingly, early on, our patients may have what's called parakinesia. So they may incorporate their chorea into voluntary movement. So maybe if there's a little bit of chorea, they may, in their, say, upper extremity, they may disguise it and maybe fix their hair and be able to transiently suppress that movement. And we know that chorea doesn't begin in, one day our patients have no chorea, the next day they have lots of chorea. The progression is slow. And so when chorea initially starts, it may be very mild, and our patients may just appear as if they're fidgety. And again, they may not even notice that they have any chorea, and that's okay. But over time, as HD progresses and as time passes, the chorea often increases and becomes a bit more pronounced and a bit more severe. Our patients may have some dystonia, which we've talked about already, so involuntary movements and abnormal postures. Our patients may experience postural instability. And so this is really described as an inability to protect your center of gravity. And so if with postural stability, if someone challenges our balance, we'll be able to protect our center of gravity and maybe take a couple of steps, but we'll be able to remain standing. But if our patients are experiencing postural instability, if in fact their balance is challenged, they will have difficulty protecting their center of gravity, and they may make several steps and continue and ultimately fall. Our patients may experience speech and swallowing difficulty, and they may have a delayed reaction time. As HD progresses, in the later stages of HD, our patients may have Parkinsonism, and this is not the same as Parkinson's disease. Parkinsonism is really a constellation of symptoms, but if our patients are experiencing Parkinsonism, they may have bradykinesia, which we've already defined, slow movements, small movements, and they may have rigidity or an increase in tone. It's important to mention that some of the medicines that we use to dampen maybe the chorea may cause some Parkinsonism. So every time we evaluate our patients, we really want to make sure that if in fact we see Parkinsonism or slowness on their exam, we want to ask ourselves, is this Huntington's and the progression of Huntington's, or is the Parkinsonism due to the medications that we're using? Do we need to back off on the dose of the medication? So we always want to look at the medication list and ask ourselves, what are we doing as the physicians that may be contributing to the symptoms? Because of course, every medication has potential side effects, and we always want to be respectful of the potential side effects of medications. So we may see that there's some slowing down of the movements as Huntington's progresses, but the chorea may continue to increase. Again, everyone is on their own course. We'll see more postural instability, and we'll see more difficulty with gait and balance. So I just briefly mentioned kind of the stages and the journey of an HD patient from a motor perspective. How do we stage HD? And I won't go into too much detail, but I often get this question from my patients, Doc, what stage am I in? And often we'll refer to the real world stages, early, middle, and late. But if we want to formally stage HD, we use the Total Functional Capacity Rating Scale, and this is part of the UHDRS, the Unified Huntington's Disease Rating Scale that I've already mentioned. And this is a scale that really helps us incorporate the motor and the non-motor symptoms. We can try to put all of the pieces together in collecting information from our patients and their loved one to determine where we are in the HD journey. So the TFC is made up of 5 domains: occupation, finances, domestic chores, activities of daily living, and the level of care that our patients require. And so we ask our patients and their families how well our patients are able to perform these various tasks, whether or not they need some help or whether or not they're struggling a little bit more than they were before. And we sum the score and we determine where we are on the HD journey. We know that the higher the score, the earlier the stage. And we know that in early HD stages 1 and 2, that individuals decrease, the TFC score decreases by roughly a point per year. But this, again, we know that everyone is on their own course, and there are certainly, everyone can manifest symptoms in their own way and progress at their own rate. So what does HD related chorea mean for our patients and their caregivers? And I think we have a good bit more work to do actually in answering this question. We as physicians, especially as movement disorder neurologists, really want to focus on treating the motor symptoms. If we see chorea, we want to treat it, maybe with a medication or non-pharmacologic strategies. But do we need to treat it? What does this mean for our patients? And so I just briefly want to mention this lovely paper that was published in 2018. And the title of this paper is Understanding How Chorea Affects Health-Related Quality of Life. And so I think this was an online survey collected from, and data was collected for both patients and caregivers in the US. And I think this is really important. This was a survey that was provided to HD participants in between February and March of 2017 via Patients Like Me. And there were a total of 115 participants included in this study. And the question was asked, how important is it to you to control or manage your chorea? And you'll see here that the majority of the respondents said very important, both individuals with HD and their caregivers. And then another important point here from the patients. The question was about how the current medication regimen, how effective is this medication regimen in managing your movements? And you'll see here that, in fact, unfortunately, the majority of individuals did not feel that their medication regimen was sufficiently controlling their chorea. There was a chorea, an HD quality of life chorea questionnaire that was given to the participants. And an HDQ life score greater than 60 indicates that an individual is reporting significant concerns that may warrant clinical follow-up due to the impact of chorea on physical and social functioning. And in fact, the majority of respondents had an HD quality of life score equal to or greater than 60. So I think that we have work to do, not only on collecting more information about what chorea means and what the motor symptoms mean for our patients and their care partners, but how can we really effectively address the motor symptoms? Let's just briefly talk about treatments. How can we address chorea? And what do we really want to do when we're evaluating our patients? What do we want to do for our patients? Our primary goal is to do our best with all the tools that we have to optimize the quality of life for our patients. And quality of life means different things for different people throughout their journey with HD. We really want to be proactive rather than reactive. So we want to think about, what are the things, and talk to our patients about what are the things that can get us into trouble with HD, and how do we minimize those complications? We really want to try to think about intervening and trying to provide our patients with various compensatory strategies to minimize the risk of complications of HD. I've mentioned already there are pharmacologic options, but there are also non-pharmacologic options. The general rule in starting medications for our patients is to start low and go slow. We don't need to rush. We don't need to start a medication at a high dose and have problems, trouble with side effects. We really can take our time and be respectful that, as I said already, every medication has potential side effects. For better or for worse, it's trial and error. So it's important that we all set realistic expectations and that we're very transparent with our patients and our patients' care partners about what we can expect from the medications and what we really can't expect from our medications. So we need to just take our time and be aware of our goals. HD, as we all know, is a multifaceted disease and requires a multidisciplinary team. So we really need our HD village, and Dr. Anderson mentioned our wonderful team. We have a fantastic group of individuals in our HD village, or as one of my favorite patients mentions, our HD multidisciplinary clinic is an HD buffet. And so we need multiple providers working with our patients and families. So first, I want to mention exercise. We all know that we should exercise. We've known that for many years, but now we have actually data to support the efficacy and exercise in HD, not only in HD, but other neurodegenerative conditions. There's actually a bit of literature for our patients with Parkinson's to support the efficacy of exercise, but we also have evidence in HD that we need to keep moving. And there are many different ways that we can exercise. We don't have to go sign up for a membership at a gym. We can exercise. We can, if it's safe, we can get outside and walk outside. We can run. We can swim. We may need to stay seated, and we may need to do range of motion exercises in our wheelchair or in our chair. But we need to do our best to remain active. So I've had one of my patients recently said, motion is lotion. And I love that we have to keep moving to the best of our ability, and that the way in which we move and exercise will change over time throughout the HD journey, but we need to keep moving. We really love physical therapy. There is evidence to support the efficacy of physical therapy, occupational therapy, and speech therapy in HD. And we may need to modify our environment to ensure that we're safe. So I'll briefly mention, I talked briefly about the importance of exercise in HD. I'll briefly mention diet. We do have some evidence to support the Mediterranean-like diet. We have a good bit of evidence in Parkinson's disease, so extrapolating from that, and a bit of evidence in HD. A Mediterranean-like diet is probably the best diet, but importantly, we know that, as I mentioned earlier, that individuals with HD can have a hard time keeping up their weight, and they may unintentionally lose weight. And so we love the HD diet because while we certainly want to make every effort to have a healthy diet, we also need to ensure that we're getting sufficient calories. So we can, and you can tell that I was hungry when I was making this slide, but we want to make sure that we are getting plenty of calories throughout the day and treating ourselves with the HD diet. And because of the chorea, as I mentioned earlier, because our patients often are moving a good bit with chorea, please ensure that we are providing sufficient calories with high calorie snacks and shakes. And there's some anecdotal evidence that they may actually help in suppressing chorea to some degree. I know I'm almost out of time, so let me just wrap up here and briefly mention medications. So we've talked about chorea, we've defined chorea. The first question we need to ask ourselves prior to starting a medication is, do we need to treat the chorea? Is the chorea in fact bothersome or troublesome? And we need to ask our patients that question, of course, because our patients are always the most important person in the room. But we also need to ask our patients, family member or loved one, are you witnessing your loved one falling more frequently? We'll ask our patient, are you dropping items? Are you knocking items over? Are you tripping frequently? Do we need to treat the chorea with medication? And I certainly won't go through this slide in detail, but I like to show this slide because I think this slide highlights the fact that we have many available medications, classes of medications to use for both the motor and the non-motor symptoms of HD. So if and when we need a medication, we have many from which to choose. There are 2 FDA-approved medications to treat Huntington's-related chorea. I suspect most of you have heard of these medications. Tetrabenazine was the first of these medications that was approved back in 2008. And then tetrabenazine, I apologize, that's misspelled, was approved in 2017 for Huntington's related chorea. So deutetrabenazine and tetrabenazine are VMAT2 inhibitors. They're brothers or cousins, similar mechanism of action. There's a third VMAT2 inhibitor that's currently under study, and you'll hear about that in a bit. But this medication is valbenazine, and its brand name is Ingrezza, and there's a clinical trial called Connect HD, and the open label extension Connect HD 2, studying the efficacy and safety of valbenazine in individuals with Huntington's related chorea. But these are not the only medications that we use to treat chorea. Often we'll use neuroleptics, or the other name for neuroleptics are antipsychotics, and these medications may be used to suppress chorea. These medications can also be helpful when we're trying to treat the non-motor symptoms, maybe the psychiatric symptoms or behavioral symptoms of HD. And I won't go into too much detail on the mechanism of action of these medications, but I will just say this is a cartoon here of these are 2 neurons or nerve cells that communicate. Our nerve cells communicate, and they communicate with different neurotransmitters. And dopamine is one of the neurotransmitters that is really important to us as movement disorder neurologists, and modulating dopamine in either trying to increase or decrease movements. And so the medications, both the VMAT2 inhibitors and the antipsychotics, work in decreasing dopamine, either decreasing dopamine release or dampening the dopamine receptors and suppressing chorea or involuntary movement.